to Tiffany for making this all happen. So maybe we could just turn it over to you.
Yes.
And oh, okay.
I can figure it out. And you can turn your mic on. There we go. All righty. Awesome. Yeah. Okay. Thank you all for having me here today. I've been to a lot of places, talking to a lot of different groups, and it's nice to be in. I've been working very closely with Suzanne here recently. So I wanted to come and talk to you a little bit today about how we engage the community in healthcare in Carroll County. So I want to start by saying that I brought some friends with me today, and I'd like to introduce them. First of all, I'm Sharon Sanders. My role at the hospital is to look at how we integrate services into the community, so how the hospital works with the community. I have our behavioral health services, I have our integrated health programs, population health, and I help oversee the Partnership for a Healthier Carroll County from the hospital standpoint. And I brought with me today Dorothy Fox, who is our CEO and Executive Director for the Partnership for a Healthier Carroll County, and she'll tell you a little bit about how that works. I also brought with me Barbara Rogers, because we also work very closely with our health department, and Barb's our Community Health Promotion Director for the Carroll County Health Department. So to start, I must say that you're going to hear that our partnership has been in place for a very long time. Only till Carroll Hospital Center became a CPR hospital did we realize the importance of the Partnership for a Healthier Carroll County. We've always supported it, and we've always thought that the health of our community was important, but we really realized how important it is for our financial health of our organization. And we're going to tell you a little bit about the partnership and its successes. Another thing I want to preface this with is we do have the Partnership for a Healthier Carroll County, and right now it's majorly Carroll Hospital Center and the Carroll County Health Department. However, one of the things that we talked about on the way down here is if we had 3 hospitals in Carroll County and if we had 2 health departments in Carroll County, all of those people would be members of this partnership, because the whole goal of the partnership is concerned with the health and health care in our community for our population. So with that said, I'll get a little bit of start. So just briefly, our view of population health. We want to know, so first of all, we want to identify what is happening in our community, and we also want to look at predicting what may happen in our community. So we have lots of things going on around that. Most importantly, we want to engage providers and patients in their health and the health delivery of their health care. And thirdly, we want to manage health and care and improve the quality of lives in our community. So what affects health? What we have to realize is that there's more than just illness that affects health. We have to look at someone's environment. We have to look at infectious agents, all kinds of concerns with different infectious agents. Obviously, their medical care, which hospitals have historically been concerned with medical care. Genetics play a huge part in the health of people in our community. Social factors, all of the social determinants of health, and how do we address those, and how do we make sure that we're addressing them for the health of our community. Lifestyle choices. We have to look at the choices people are making as it relates to their health. Smoking, overeating, eating the right foods, all of that stuff, as well as the environment that they live in. Where do they live? Do they have a home? What kind of factors in their environment are affecting their health? So all of these things we become concerned about as healthcare organizations, because our goal is to keep people healthy in their community and out of expensive hospital care. So that's really what our focus has been. So why is engagement important? Engaging patients who have chronic disease to better manage their disease is extremely important. And I know you guys have seen the whole people with chronic disease spend the most money in America. Then there's another level of high-risk people. So they're at risk for getting chronic disease because they either have a family history or they have high blood pressure or they have other things that may cause them to develop congestive heart failure in the future. And then we have this group of people down here that are well. They're healthy, they're stable. So really what we want to focus on is keeping the well people well. We want to educate those who are at high risk for chronic disease on what they need to do to prevent from getting the chronic disease, make sure they're getting the medications they need. And then those people up here who have chronic disease, we want to help them better manage their disease. One thing that we realized that we were focusing a whole lot on is managing people with chronic disease. But what we quickly came to learn is that it's just important to focus on the people who are at high risk and the people who are well, so that we address everyone and we prevent. It becomes more about prevention and less about management. So with that said, I'm going to let Dot talk a little bit about the partnership and how we do all this.
Okay. So the partnership was established and incorporated in 1999 after an initial community needs assessment suggested that there was a need for a coordinating hub. So progressive and forward-thinking leaders at Carroll Hospital Center and Carroll Health Department got together and formed this unique entity known as the Partnership for a Healthier Carroll County. Okay. And because of the hospitals and the health department's continued support, it not only allows the partnership to remain a viable organization, but it also allows the board of directors to truly be a governing board and be able to focus on making true impact and results in the community and the needs assessment. So the mission of the health department is to strive to build the capacity of individuals and organizations to improve the health and quality of life in Carroll County. And we really do this through organizing skilled and influential leadership teams and action teams. That one. Okay. So I went too far, sorry. There we go. So the partnership, as I said before, is really a unique entity, and I'm very proud to be part of this. We do not provide a direct service. We do not sell a product. Some of the things we do is we work with other organizations. We promote the healthy lifestyle. We truly advocate for some of the changes at a policy level in the community. And our tagline is actually at the top: connecting people, inspiring action, and strengthening community. And we really think that we do that. It says what we do. One of the most important things that we do is assess, track, and interpret the health data. We spend a lot of time with that. Get to the next slide. And this slide kind of shows how that happens. This is a very important slide if you look at it from a strategic level point of view. The community health needs assessment will drive the community health benefit plan. Now, in that plan, it's really interesting because we not only have the hospital, it's not just the hospital plan, it's not only the health department's plan or the partnership, but we also have Carroll County Public Schools in that plan. We have the libraries in that plan. We have Access Carroll, which is a medical home for the underinsured. They're also included in that plan. So that in turn, they can build that into their strategic plan. So we'll see that flow go into their strategic plan. It creates that shared sense of responsibility, that shared accountability. So then we're able to see that it directs the service lines. It directs the leadership teams. It really gives it directions. And then we come full circle again back to the next needs assessment. So this is a priority that happens every 3 years. And I think what's being passed around now are the community benefit plan. Yeah. And we also brought a few copies of our vital signs, and I always call it our companion piece. And this is our measurement tool that we use. It's updated twice a year. So the structure of the partnership, it truly is just a continuing sequence of assessing, engagement, and measuring. And then This slide kind of repeats some of what I said, but we're looking at it from now a big picture, community picture, and bringing it down. So here we have the needs assessment. We prioritize the key areas, the prevalent areas, and then we can actually create large health improvement areas out of that. And from those health improvement areas, we design leadership teams and action teams. And I'm going to let Barb take over from here to talk a little bit more about what the leadership teams and action teams look like.
Okay, I was good before. I'm going to show you how we do this at the partnership. We have what we call 5 community health improvement areas, and within that we have 4 leadership teams. I just so happen to be the person who's in charge of the Access to Healthcare leadership team, which encompasses a lot of areas. So as you see in our box here in the middle, that's what we would call our leadership team. We have roughly about 44 different community folks that all sit on that leadership team. And then what we do is we basically try to use the guidance of our planning, the vital signs that just went around. We look at all the data and we say, okay, so what do we as a group get together need to do? And so what we have done historically is we've created action teams off of the leadership team. And we call them community action teams. And one of the best examples that we have to show you what's been created and sustained out of that group is Access Carol, which I'm not sure if you all are familiar with what Access Carol is, but that is a free primary care clinic that's been around since about 2005. Because we found that was a great need. We had a small clinic that was running at the health department where we had folks who just didn't have insurance and didn't have a way of accessing care that really we needed to solve that problem. And this group got together and said, hey, how can we do this? Who do we need to bring together? And we now have a really absolutely beautiful facility that's given to Access Carol by our county government. If you haven't had a chance to go for a tour there, give Tammy Black a call. She would love to give you a tour. And the numbers, while we thought here for a little while with the Affordable Care Act, we'd see those numbers going down, they're actually pretty much staying the same or going up a little bit. And I think it's because folks are still needing that extra case management hand-holding to get through the system even though they have insurance. Just because you have insurance doesn't mean you get the care. So I think that's where Access Carol plays a huge role in that. The second thing that we did, too, if you all remember back in 2011 when local health departments were encouraged to create what we call LHICs, Local Health Improvement Coalitions. I happen to be the co-chair along with Dr. Henry Taylor, who's my boss, in Carroll County, and back then we had the opportunity to go after a small amount of money, and we had to decide within this group what were we going to focus on. And we decided that looking at the data once again and going back, we decided that we were really having an issue with the number of folks presenting at the emergency department with behavioral health issues. And they were pretty much frequent flyers and things like that. So what we did, high utilizers, well, they're, yeah, well, yeah. And so basically what we did was we went into the community and we said, you know, we did this for $25,000, needless to say. I don't know if Mark Luckner's listening, but that's all I was given. So, but we did a really great job, and we worked with community members, and we got an outpatient mental health clinic model going, and basically it really kept the numbers down from those people presenting back at the emergency department, and they were getting an appointment either same day or next day in the community at this clinic. So that, and Sharon's going to expand upon where that has gone. I'm giving you where it started. So then more to this is that basically we want you to understand that some of these things may have originated in the partnership, and remember this is only one area. We have the 4 other leadership teams who have all created very similar models, but you know, if you want to know more about that, go to our website. You like that, Dot? Because every group has done this. Access to Healthcare just happens to be the oldest leadership team. I guess that's why I was able to be here. We were 15 years old in January, and that group has gotten really tight, being 15 years of a lot of the same people. We actually just had a meeting this Wednesday, and it's a really passionate, is the way I would put it, group of people from all aspects of the community that come together. And we do serve as the Local Health Improvement Team, which is a subcommittee of our Local Health Improvement Coalition, so that we keep things moving. So what we do have currently, how this works, is we do have action teams that shoot directly right off the leadership team, and these are the ones that are still functioning. And you might say they haven't gone off and become, wonderful services in the community. And we've always used this 4 criteria to identify what should we be working on. And so what you'll see up there is we first of all look at what is the burden to health, and then we actually what is available of current data, and then what is the capacity and willingness of this group of people to wrap their heads around all these problems and solve them. And then we use evidence-based best practice models and tools to come up what should we do to address them. So recently we've taken on some of these new activities. As you will see, we do something called a cross-agency training, which has really taken a lot of agencies in the county, and we've cross-trained each other. And we do these crazy scenarios where we work through if you have a client who has this problem and this problem and this problem, how do we resolve all those problems? How, we've even, we give away some real big secrets within organizations where we give the secret phone number. So if you have a client, you can say, look, how do I help this person right away? This can't wait till, it happens. We all know this all happens on Friday afternoon. And, it can't yet 5 p.m. and you can't wait, so you need that person's phone number. Another area that we've put a lot of emphasis into is transportation, because in Carroll County, transportation is an issue at all levels. And, we have some fairly rural areas that people have difficulty getting to health care, to their health appointments. And then we're starting a new group here coming up that's going to be Medicare Advocacy, because we're seeing a lot of issues with Medicare, the LCPC versus LCSWC, who can be reimbursed, those people who can't get the services in a timely manner. Some of the, Sharon and I have been looking at this whole observation in the emergency department situation, which you all I know are familiar with. And then the very last thing we've just recently gotten into, I'd say only within a month, has been the Faith Community Health Network, which I know you all have heard about that. If not, you haven't been listening to Vinny then. And so we are the group that is going to basically have that action team serve, basically under this model that we have here that we've shown you. And this has been around a long time, and I was just explaining to them how I love this slide, and it's like on my, it's my screensaver, but it just keeps reminding me of, how does this work, because you can't skip the model or you'll miss something. And this slide is basically summing it all up for you, how the hospital, the health department, basically formed the partnership with the community. Originally, we had this logo that was like a triangle, and I think it was a good representation. I still like our swishy dancing people, but it really was about the health department, the hospital, and the community. And the partnership was started by a 17-member steering committee back in 1999, and it has continued to grow and change with everything that the health departments had to go through, with everything the hospitals had to go through. So it's kept us quite busy. And just this, I won't spend a lot of time on, because I'm sure you all know what an LHIC is, but I just want to make sure that you realize that the partnership in our county is a little bit different, because what we did back in 2011 is we decided, instead of reinventing a group, we've had a group that's been around since 1999 doing their job as our board of directors, so we certainly didn't want to go off and create a whole big brand new group and say, oh, you guys don't do something else. So we've kept them involved, and back in October 2011, our partnership board of directors, who is well represented across, we have citizenry, we have the school system, we have law enforcement, we have the libraries, we have both colleges. I'm trying to think, we have a lot, it's a lot of people. And we deliberately, we of course hospital and health department, and we deliberately make sure we have the community represented from all geographical areas of the community as well. So, and I'm sure you all know what our job is. We have to look at the SHIP data, we have to do a local health improvement plan process, and what we try to do then is really tie this all together with community benefit and the partnership strategic plan. So what we did do most recently outside of our model, because, yes, it was all the hospital's fault. No, basically we decided that the partnership, as Dot told you, was not a big direct service delivery agency. And we did that on purpose. Historically, we didn't want to get into healthcare. We were perfectly happy letting, the hospital and the health department do their healthcare delivery pieces. But what we've discovered we really needed to do, and we've been around now a little over a year, we created a population health governance group. And what that is a group of people from the hospital, people from the health department, people from the county government. We are going to be adding a community representative. I think the city manager of Tawnytown, as a citizen, would like to we think she really wants to do it, so I'm sure she will entertain that idea. She's very into her community in Tawnytown. So basically that group all gets together once a month and says, what are these, what should we be working on? What are the populations we should be looking at? What can we fix? And we're pulling in and tying in the health care aspect of this more so than we have done in the past with the partnership. So this is kind of a new, challenge that we're going into. These are the current members that are on that group. And as I said, we're going to add some citizens who we really feel can only add to it and guide that. Back to you.
So as you can tell, we all do a lot of work together. And one of the biggest reasons we formed our population health governance group is because we really wanted to look at preventing duplication of efforts. We wanted to make sure that the health department wasn't running around doing a bunch of stuff, the hospital wasn't running around doing a bunch of stuff, other community agencies, the county government wasn't running around doing a bunch of things, because we do have a citizen services department who is looking at aging and other things. So we felt like we all needed to get together in the same room on a regular basis and go over what our priorities are. And really what's been unique about the population health governance group is that the priorities of that team have really become this stuff right here, based on what the community needs assessment has shown and what our community benefit plan is. So I want to give you an example of one of our targeted collaborative efforts that we've done and some of the success. We've done many, but Barb came today. We have, so through the partnership, we have many leadership teams. Access to health care is just one of them. We have other, I think 6 or 7 other?
We have 4 leadership
teams and then 5 areas. Yeah, I keep getting the numbers messed up.
Prevention and intervention, chronic disease prevention and intervention combined for one leadership team.
So through access to health care, one of the examples that Barb mentioned was our behavioral health outpatient mental health clinic model. One of the things we found is that the majority of our ER visits were some sort of behavioral health issue related. They also, we did the community needs assessment, and behavioral health and substance abuse in our county came back among the highest issues with our community. So we really felt like we needed to look at a system of care for our behavioral health patients and our mental health providers. So there's a behavioral health advisory council in our county, and we brought them together and we said, what can we do? This council provides oversight of the system coordination for the county. The most important thing is that it contains necessary stakeholders. So you've heard from Dot, you've heard from Barb, you're going to hear from me. Anytime we sit down and do something now, we make sure that it's not just the hospital saying, this is what we need to do, and here's what you're going to do. We bring all the stakeholders to the table because oftentimes we found by just listening to other people, they're able to give us some really good ideas that we might not have thought about in the past. So when this one particularly contains law enforcement, has a judge, there's mental health providers, there's community members, hospital folks, health department folks. I think there's like 40-some people that come to these meetings. It's structured as a board, and it has many committees and work groups. So the work groups and the committees function closely aligned with the partnership. And as a matter of fact, some of the work groups that are formed by this council become action teams of the partnership. So in this case, some of the major initiatives that they've really worked on, behavioral health and substance abuse was identified as a high priority. They engaged peer support specialists to work with the community. And every community has these peer support specialists. But what is unique and what we've been able to do is we've been able to embed them in critical places. So we talked about Access Carroll. There's one that goes there. We have one at Carroll Hospital Center that all of the staff know. They know his name. They know his number. They know his secret phone number. They know everything about him, so that when we have a patient who comes in our emergency department or we have somebody leaving our behavioral health unit that has a behavioral health or substance abuse issue, we can connect him with the person. So he basically becomes our behavioral health navigator.
I was just curious if you could describe kind of what that
Peer support
person's
specialist,
training
yeah.
and
So,
role is.
Right. So peer support specialists are people who have had behavioral health issues or a history of substance abuse. Okay, so they are recovering people who have successfully been identified. I think they have to be so long out of recovery. I want to say 2 years out of recovery. And they are interviewed and employed by the Carroll County Health Department. And they go through a series of training classes. There's specific topics to each of those classes. They're taught what to say, what not to say. There's other hours. They have to spend so many hours of time working with someone else before they start working with someone by themselves. I did another presentation. I actually have another slide that explains everything they do particularly. If you want, I can send that to Tiffany, and she can get it out to the team, too. And they are then turned loose in the community, and they are actually embedded in different places. So they work at the health department, they work at Access Carroll, they work at, is there any other places they go? They go in the hospital, on our own. Different other agencies have them working within their agency. And the theory is that they navigate the person. So they're one of them. You know, they've been in their shoes. They can relate better to these people than you or I sitting there talking to them. And they can oftentimes help that person to be more successful in the community. Okay. Another thing we realized is that we had an issue getting people into appointments in a timely fashion. So we really had to create a system where we had mental health same-day appointments. You know, when you have someone in, you know, one of the things that we've learned through I've been to many, many seminars, and I've heard when you're dealing with someone who has mental health or depression, the one thing you don't want to do is say, okay, well, I want you to go see Dr. So-and-so, and they'll help you with your problem. The problem is when you call Dr. So-and-so, they can't get you in for 4 weeks. And by then, you're either not going to go to that appointment or you're back in the hospital. Right. So what we did was we created same-day mental health appointments so that they could get their counseling, try to get them in with the doctor for their meds management in a more timely fashion, and that seemed to really take off. We also had crisis beds in the community. Rather than utilizing the emergency department, we actually trained law enforcement people to utilize these crisis beds. Instead of bringing people who weren't seriously ill to the emergency department, they can utilize these crisis beds. And they're at, where are they at? They're located over at the other end of the county, in Yeah, they're right. Yeah, on the grounds of Springfield. And then also the problem was we didn't have a good way to communicate referrals. So one agency had this referral form, another agency had this referral form, another agency had this referral form. So we developed the universal referral form so that social workers in the emergency department could just refer out to all these agencies, and we had one referral form. They didn't have to work on multiple forms and multiple referrals to multiple agencies. And again, I said we engaged and trained members of law enforcement and other community partners to know what all these services were that were available so that they could use those rather than bring patients to our emergency department.
And one of our most recent added things is the the crisis intervention teams in Carroll County that we've just started. We trained, I want to say they've trained like 15 law enforcement, and they've got like, I want to say 17 more they're going to do in the fall. That's mostly Sheriff's Department, because that had not existed in our county, the crisis intervention teams.
Right. So, our results. So in the first slide, the first chart you see on the left is our inpatient hospital average daily census. We went from being just about full, a 20-bed unit, 16, down to an average daily census of 10. Rarely do we have above 12 patients in our inpatient unit. So over the last several years, we've really been able to decrease the number of patients requiring inpatient hospitalization. And then visits to the emergency department, we had a hard time trying to figure out how we were going to count that because, there's people who come in for other issues that get a behavioral health evaluation. So we decided to look at, we do social work evaluations on all of our behavioral health patients. No matter if they have come in with a medical problem and we identify a behavioral health issue, they'll be seen by a social worker. So we took the social work evaluations and we were able to decrease them from we were up to about 3,000 at one point, down to roughly under 2,000 per year now. So that's a huge jump for us. So we were able to reduce the number of readmissions. I don't have these slides here, but we were, this is the high utilizers. So the first one is high utilizers, patients with 3 or more inpatient admissions. Went from fiscal 12, we had 87 patients with 3 or more inpatient admissions, down to 49 in FY14. And so that was really a 44% reduction. And then our high utilizers with 10 or more ED encounters. So, and this is not per year, this is per month, okay? So because we're the only hospital in town, our ED high utilization overall is defined as 3 or more visits to the hospital per month, okay? So 10 or more ED encounters per month went from 83 unique patients down to 48 unique patients. So we were able to decrease that by 42% just by getting those people to love on them, getting them the services they need out in the community rather than in our hospital. So I will tell you from a sustainability standpoint on a lot of these programs, we've had success for other, diabetes and all these other things. For this program, would lay down in front of a train before I would let it go away because it really has been a huge success in our community. And we fully support all of these programs. As a matter of fact, the crisis beds, they were in danger of going away because we lost the funding for a lot of this stuff. So we got together as a county and we said, okay, Carroll Hospital Center is going to provide the social work evaluations, you provide this, you provide that. We all got together and we were able to sustain those programs by getting together and saying, we're all going to pitch in and do this because we see the value and we don't want it to go away. So that's another benefit of the partnership is that, when something's at risk to go away, we make a phone call and everybody comes together and says, we can't get rid of this program, it must stay, or that program, or whatever. So I know we've done a lot of talking. I wanted to let you ask some questions, and I hope we covered some of the things you wanted to hear today.
I want to make a comment and then ask a question. So I'm very pleased and happy that you came and applaud you for the work that you're doing and the passion that you have, and it's wonderful to hear. I have one question about your dashboard. So if you look under the mental health substance abuse, number 3, since I work for the Healthcare Commission, the Cost Review Commission, it says that you're, this is, I think this is SHIP data, is that right? Is it a SHIP data?
Yeah.
Is it SHIP or is it, I can't tell from the key.
It's community benefit, yes.
HIP?
Yeah.
Okay, that's an internal metric that you
Right.
use. Okay, so it looks as if the rate's going up. Even it's a little bit different than what was in the slides, but maybe the time period.
It's old data. That's
Okay.
old.
The
So
other,
I think we'll find from our new community
Yeah.
assessment that it'll be down. We don't
Right.
do it every 3 years.
right, but one issue is that these are sort of raw numbers and not percentages, so of total population. So it's hard to tell whether this is a good or bad number. If you have more population you're serving, 467 may be better than the year before if you're serving more people.
Right. So this
So
is all new
that's
to us. This whole dashboard here is all new to us. The Healthy Carol Vital Signs for us, and putting all of these measures on here. As a matter of fact, one of our goals for this past year was to try to get numbers to these measures. That's the most difficult part. So this is our attempt at trying to track.
I did perform measurement work
Yeah.
Here,
Yeah.
and I love the transparency of this, I have to say. So that is extremely appreciated.
Right.
And good consumer engagement, if I may bring us back to the name
Yes.
of our task force.
Exactly. Exactly. Yeah.
Thank you for your presentation, and a lot of great information, great models. One of the things you mentioned early in the presentation was the sort of risk pyramid, and the models that I heard you speak about were more focused at the top end of that pyramid. I wondered if you could talk a little bit about what you're doing in your community to address the middle and the folks that are healthy and you want to stay healthy.
Right. We do have our prevention, it's chronic disease prevention team. So they work a lot more on the prevention aspect. So some of the examples, our needs assessment had obesity identified as #1, and a lot of the chronic diseases followed the trend. So we had diabetes, everything was related to that obesity. So we've created a countywide walking program. We walk with the mayors in each town. We walk with the commissioners are now trying to get into this. So each library now has formed their own walking group. It just continues to expand. So we have a lot of community-wide programs that address our #1 indicator, which is obesity. So there are other prevention messages. We do Safer in the Shade. So we plant trees around places where children play, and we talk about skin cancer prevention. We also do Fun in the Sun, where we go out to pools and we make sure that we are allowing them to understand the two methods of protection for sun safety. So we do have a prevention message as well.
And how do you get people into those programs? How do you promote them to?
We can talk about that all the time.
We go to where they are.
Yeah.
Yeah.
Absolutely.
You know, that's
Are
the
you going to tell them your birth
Oh,
story?
I can tell the bird story. Okay, so everywhere I go, I have a bird story. Okay, so everywhere I go, if you have a target and you have a person and you're throwing a rock, eventually you can make the rock hit that target. If you keep throwing and practicing, the rock will hit the target. But if you have a bird and you try to throw the bird at the target, the bird, you can aim it for the target, but the bird is going to go where it feels most comfortable, typically to its nest with its baby birds. So if you take a birdhouse and the nest and you put it in front of the target and you throw the bird's more likely to fly to the target. So the whole point is people are more like birds and not like rocks. So you can't control them by practicing. So you kind of have to go where they are, and you have to take the services to where they are, and you have to take the message to where they are. So the whole point with the walking program and how do we get that out there, we go to the mayors, we go to the towns, we go to the places where people live, and we promote the programs. We actually go out and walk ourselves. Dot's been on many walks with these people, you know, and we demonstrate and we show and we try to get people to come along with us. And so I guess the point is you can't force people to do what you want them to do, but if you take the things to them and try to get them to see the importance of those things, then eventually you'll have one more person joining you and another person joining you, and eventually the mayor's leading a walk. One town, the mayor leads a walk every Tuesday.
Oh, wow.
Yeah. So, that's the point. You have to take the stuff to where the people are. You can't say, we're going to have a walk today in Westminster. Nobody's going to come. You take it to where they live.
And just to add to that, it's really exciting because we'll be out walking with the mayor, and we'll have 10 people walking with us. But as people are planting flowers or walking their dogs, they turn around and join us.
Yeah.
They just join in, and it's a wonderful experience. It's wonderful for the mayors, and it's wonderful for all the people. They're getting to know each other. It's just a great community promotion effort all around.
And if you listen to Leslie Simmons, our CEO, her motto is start and continue. So you got to start somewhere, and you just got to keep going. So that's kind of how we approach it. But taking the services to where the people, even at the hospital, we've realized we've always had an outpatient center, and we've always had these siloed places. And even we're realizing that we have to take the stuff to where people are, that, the education to their churches. We have to participate in the faith community network. We have to try to do these things to take the stuff where the people are.
So it's a great example of civic engagement. Thank you for the presentation, because you can, the promotion is that a citizen can actually get to walk and talk to the mayor and give them their
opinion,
concern, right? So civic and consumer engagement in marketing is interesting. I'll ask one question and then let others. I'm interested in how you actively recruit for the
leadership team.
Yeah.
May I just answer some of the questions also?
Great.
Which is not only how do you recruit, but how do you control for not having the same people represented on all these councils? Because you have quite a few people. I'm wondering, how do you find unique people to serve on these various groups?
We really have not. Now, you may be able to speak more to at the beginning of the organization, the founding of the organization, but people are really interested in being on the teams. We don't struggle with getting people there. We might reach out. We're looking right now at a behavioral resource guide, and I did reach out to the library and say, who would you like to sit on this team? But because there are such great partnerships already developed with the organizations, it's very easy to do. It's also very important, the leadership that I have on my board. I have a very strong board. I have all of the members of the board are not only representative of those organizations like the school system, but I have the assistant superintendent of the school system as my chair. I have the director of all the county libraries on my board. So I have the people that are able to make those policy changes. Once you have the people at that level sitting on your board, you're really able to make a phone call and get the right people at the table. We have Parks and Rec sitting there, so you have the lead organizations, and so you can get into the pools. It's very easy, and once it's seen by a few members, everybody wants to join in.
It's a lot of selling, too, so when you're looking at a leadership team, so for instance, let's go back to the behavioral health team. We know that there's a lot of agencies in the community that struggle with all of this. So we put the word out there, and we try to, get people engaged in the things that are interesting to them. So if we, from a community agency standpoint, we say, okay, well, we have this problem. Here's our problem, and here's our issue, and we would like you to come help us solve that, rather than here's our issue, we're going to come up with a solution, and we'll let you know when we do. So.
Talking about the
agency. You're talking about the people.
So how do you get if I can say this, real people, right?
Right, real people. So how do you
mean like the action team people? The people that do the work.
Yeah.
Or those that are representing the consumer interest, if
Correct.
I can.
Correct.
Not that the big people aren't, they're representing
we
it too.
also work with a lot of, so we have a lot of little advocacy groups, people that are advocates for the senior population or advocates for this or that, and we do involve them in our groups. Like we have an elder health team. We do have some groups out there that are specifically interested in the aging population. They're not healthcare providers, they're not providers, they're not part of any kind of provider, but they want to they've either had family issues or they've had a personal issue, or they own an assisted living facility and they have resident issues. So we do bring all of those people together in the county we have a systems of care group that meets within the county, and that's led by myself and Madeline Maury, our Director of Citizen Services for the county. And we have different little groups off of that. So we really try to draw in the people based on what their interests are. So if someone contacts us and says, I really have a concern with the elderly, or my father this, or my mother that, within the hospital we have consumer people sitting on the groups. But as we learn things that are big issues, we create bigger groups and pull them in. So I guess to answer your question, it really depends on the issue. We don't have specific consumer advocacy groups, but we pull consumers into the problems based on what the issue is and what we've learned the issue. Yeah. Right. Yeah.
Right. Well, and the other thing I want to mention is that the partnership has an annual meeting every year in May. We call it We're On Our Way, and we give everybody a free, really nice breakfast. And the idea behind that is everybody in the community can come to that. And I'll be honest, that's probably when we see more community members come out just to figure out what the heck is this partnership thing. And what we do there is we present what's happened in the past year and what are we going to work on in the next year. And during that registration process and everything, we ask folks, what do you have an interest in, and would you like to be on a team? And every year we recruit a lot of people. And they really stick to it because they self-select what their interest is, which group they're interested in. And those, in fact, we have one coming up on May 20th if you'd like to come. I think I'm okay to invite you.
Yeah.
We got plenty of space. We usually have, 150, 160 people come to that. And what's interesting to me is every year it's not necessarily the same group. You do get new people that come out to that because they're willing to come out to something that's in a really big group like that and figure it out first and then decide how they want to get involved versus coming to like a really tiny group where they might only be, one of a handful of folks. So they come and they can kind of hear and make their own decision how they want to be involved. And that's actually been very successful for us doing it that way.
Great.
Free breakfast goes a long way.
Are there more questions in the room? Oh, Steve, yeah.
This is Steve Ports with the HSCRC. One of the things, I have a comment and a question. One of the things that we've seen, if you read the community benefit reports over the last couple of years, which I know you do, one of the common themes that we've seen throughout there is there's a question on there that says, what needs are you believe in your community are unmet? And almost all of the hospitals have said behavioral health. It's a real challenge. So I guess my comment is thank you for at least trying to address a major issue that everybody acknowledges and many have not been able to address. And it remains to be seen with data and so forth the success of the program. But I would suggest if you're prepared to do that, this needs to be shared. Your successes need to be shared with other hospitals. I know because this is not a competitive issue between and among hospitals. All hospitals should be trying to address, first of all, the high need. These are high needs patients, but they should also learn some of the successes of the program and be able potentially to provide those services or something similar.
Sharon got invited to speak at the Emergency Medicine Associates and the education, MHEI, had a conference down in Baltimore a couple weeks ago. And I was on panel, and my topic was reducing ED high utilization. So how do we do that through navigation? So I took the peer support program and used that as an example and our behavioral health stuff as an example. And I only had 7 minutes to speak and then a panel. So I really couldn't give them a whole lot of information, but I was, after the meeting, you'll be happy to know, approached by a lot of different hospitals who want to come and meet with us. We've actually had Frederick Hospital and Adventist, not Washington Adventist, but Shady Grove, or what is it called? Help me. Washington Adventist Shady Grove, yeah, that one. Yeah. They've actually called, and a couple others are going to come and talk to the members of our behavioral health on the health department, my behavioral health team, and get together and really go into some depth about how we do that. So they're very interested, and they are calling, and we're sharing it wherever we can.
And MHA might be a resource. They have a care transitions group that may be interested in this. But my question is more consumer-oriented, Lenny.
Can I make a quick announcement? They're parked in handicapped spaces are a Mercedes and a Jaguar, neither which are mine, sorry to say.
Sorry to say it's not mine either.
They need to be moved if they belong to somebody in this room. Okay. Okay. Sorry, Steve. Go ahead.
Oh, no, you want. So my question is, again, thank you, and trying to address a tough issue. My question is, a lot of your plan, your health improvement plan, is based on the CHNA, the Community Health Needs Assessment.
Right.
And we've been promoting collaboration and development of the CHNA. My question is, to what extent and it kind of piggybacks on what Lenny was saying, to what extent are consumers, community providers, LHIC, the LHIC and the local health department, to what extent are they involved in developing the CHNA or the priorities? Because everything kind of starts there, not with, and the health plan is the next step of that. So we want to make sure that consumers have a say at that very first stage of the process.
The partnership actually leads the needs assessment for Carroll County. And on that committee, of course, I have the hospital and the health department. We reach out to the community. I hear your comment. You're saying on that initial planning of that needs assessment, but we do include our focus groups. We go into the community. We go to locations to actually do specific focus groups to include in the needs assessment.
And then once the survey's done, we get everybody in the room. So consumer people, we get the hospital, the health department, other interested agencies all come together in the room, and we have a whole day where we do a prioritization process. So that's how we prioritize the community needs.
So I would suggest Lenny,
so if you want to come,
the
you're
consumer
welcome.
leader, I would suggest that Lenny, Tiffany, whoever would also be notified in the future of those meetings, and they can help make sure people in that community that they work with are part of that process.
Yeah.
Just a suggestion.
Absolutely. Absolutely. The more the merrier. As far as that prioritization process goes, the more the merrier, because it really helps us get to the meat of what the problems are. But we do have a whole day that we all get. And so our community needs assessment is going on now. We complete that, and I think you said by the fall we'd be ready to do the prioritization process. So, sure.
Yeah, I mean, part of the task of this group is looking at these opportunities and providing recommendations, not only to the commissioners, but then working with the hospitals and others. Yep. So we really look forward to ongoing. We need to sort of wrap this up. But I know Susan had a question, right?
A comment and a question, and thank you so much for your presentation. It was wonderful. My first question is around how are you funded and continue to have continuous support to continue to move the needle? And then the other piece of it is, I have two questions actually, is how is the consumer, specifically related to behavioral health, how has the consumer voice come through in terms of system change? And have they been able to have a voice to influence that, or at least give feedback around? Because you've actually, I mean, we all know that those people are, if they were choking the ED, they're used to going there. They know the providers there. They have relationships. They like that. And so when you move that, how has that worked?
I'll answer the first part. We learn a lot from these peer support specialists. They're the consumers out there really getting the meat of the problems and hearing from the people. So we get a lot of trends, a lot of feedback back from these people, and we use that feedback to try to change our program or tailor. I can tell you that the guy that works at our hospital, he's calling me constantly saying, or calling Brian Henline, our executive director, saying, this isn't quite working or that's not quite working, or I've seen 10 people and, they don't want to go to this for this reason, and is there any way we can change that? So there are our eyes and ears in the community as far as that goes, how we're getting that feedback back. And I'll let Dot address the budget funding.
The funding comes in multiple ways. We, of course, do get some grants we apply for, but mostly we have our financial funding comes from the hospital, but a bigger portion of that is actually the in-kind funding that I receive from the hospital and from the health department. There are staff that are, health department staff that are dedicated to the partnership. So I have staff working on the partnership objectives that work both at the hospital and the health department. I'm housed by the hospital as well, and have access to their services, such as IT and marketing. So,
and she reports directly to me, so we have that back and forth all the time.
Right.
I have just one quick question. In terms of, you have a lot, first of all, thank you. It's very impressive. And you have a lot of moving parts and a lot of things going on. And so I'm just wondering in some way how you're measuring your success in terms of which are the interventions that are successful. You talk a lot about the peer supports, which clearly are meaningful, but are they tracking? Are you measuring? How are you determining that those are, which interventions are the successful?
So for us, at the hospital, data analytics has been a challenge in looking at the success of each program. But it's very important that we see what we're spending our money on, and we're getting value for our dollar. So we're in the process now of looking at all of our programs, evaluating even as much as our community we have community navigators that are out there. So we're looking at what populations they're seeing. We're looking to see if our readmission rates are reducing in those populations, or our ED utilization is reducing in those populations. So similar to what we've done with behavioral health, and we've said, okay, we have all of these things in place. We know the peer support specialists are working. We know the crisis beds, and we know the same-day mental health appointments have been working because we've got the data to show that, and we look at that. We have other issues and other people that are out there doing a lot of work that we just in our gut feel are successful, but we want to show those numbers. So that's kind of the process we're going through with our hospital now, and to try to get some real data.
Right, and so I can add to that the metrics the commission looks at have to do with readmissions, ED visits, observation. So you're sort of hovering around the targets, I see. So.
And I think that you'll find that we've done a ton of work, and we're hoping that that's way down soon.
Great. Well, thank you very much. That was very informative and useful for our work, and I think we look forward to continuing to partner.
And do to help, always hard for you. Feel free to call me. And feel free to send people our way. Like we're not competitors. We want to share. In a global budget environment, we've been TPR now for 5 years, so we don't care. We'll share all our secrets. We want everybody to know because it's about keeping people in the community, and whatever we can do to help with that, we're more than willing to do that.
And all our LHIC meetings are open to the general public, and on occasion we have somebody shows up and then they kind of get into
a payer that comes. So
United Healthcare comes.
I do, because we don't have time today, I'd be really interested to pursue a conversation about how you're addressing the social determinants of health. I mean, you mentioned transportation, so I will be looking for a card because that will also be germane to what we're doing. But we do need to move on. But you do not
wanted an example of what we did. So we gave it to you.
Well, we're not kicking you out. You're welcome to stay if you want to. So, but we're going to move on with a couple of updates. First of all, on the Consumer Outreach Task Force. So that's Suzanne?
Yeah, hi.
Hi.
Thank you so much. And thank you also to folks from Carroll. It's been a pleasure working with you. It's great to see you here. But just to give you a little bit of an update of what we've been doing through the Consumer Outreach Task Force, we've already had 5 of our public forums that have been very well attended. We've got great feedback from them, and a special thanks to the Consumer Outreach and Engagement Subgroup that's sort of helping to coordinate some of the work between these 2 work groups. They helped us update our evaluation form that we've been distributing at these forums, and we've gotten some really good feedback about where people are in their awareness about health system transformation and this waiver, and how they want to receive this information, how they can be more involved, and who they want to get it from. So we'll definitely be sharing that. We're updating that evaluation form for the next couple of forums, which are planning on being held. The very next one that we're hosting is April 20th in Southern Maryland in Charles County, and Secretary Van Mitchell will be there. It's at 6 p.m. at St. Charles High School for anyone who's interested in coming. I believe all of these dates and locations and everything that you would need to know to come and participate are on the Basecamp calendar, as well as on our healthcareforall.com website. So if you want to pass anyone that way. We have other forums coming up in Western Maryland, Baltimore County, Montgomery County, thanks to Holy Cross Hospital for hosting that, and Arundel County and Baltimore City. All those dates are on our website. There will probably be at least 2 or 3 additional ones in Baltimore City. We're still working with Dr. Nguyen on a lot of those details, so please stay tuned as we have more information on that. Again, we are going to be doing a report kind of collecting all of our learnings from these public forums that we're expecting to have in July. And we'll continue to work with the subgroup on making sure that those that we're all literally on the same page and that it's a good fit with the other report that we're about to talk about. So,
and
is
July 7th
the Baltimore City one?
Is that projected now to be the last one before? I mean, she may do more in the future, but is that kind of an end date for this first round?
Well, we're still working on setting the Baltimore City ones. It's not clear if they would happen before or after that. That's the moving target that I can't give you an end.
So July 7th is not an end date we can count on. Let's put it that way. Okay, for our planning purposes. Great, thanks.
We'll keep you informed as soon as we know an update.
Just trying to figure it out. Yep.
Sure. Are there any questions or feedback?
Talk about the merged.
Thank you, Suzanne. So we have this consumer outreach and engagement subgroup that Suzanne just referenced that has 3 representatives from the Consumer Engagement Task Force and 3 representatives from the Consumer Outreach Task Force. And the charge of that group is just to bring alignment between the work that's being done by the individual task forces. And so we've solicited feedback and input over the last couple of meetings, subgroup meetings and task force meetings, to help to develop this evaluation or to add to the evaluation that the forums had already had. And it was really nice. The task force was very receptive to that and really responsive, because the first time that we used it, within maybe at 24 hours, Suzanne had compiled the results and shared them, and so we were really encouraged by that. And so our subgroup has been meeting. We're planning to meet after every forum or after every group of forums just to look at the evaluation results to see if there's information that is helpful, if we need to tweak things, if there's other information that we'd like to get. So we want to use that as primary data, as well as other feedback that's being received at the forums and through the subgroup work, to make sure that our reports, our respective reports to the Commission, are as informative and as informed as possible. So at our last meeting, there was discussion about how the Consumer Outreach Task Force is working with MedCai to engage providers. And so we agreed that, I was going to call myself, refer to myself in the third person. We agreed that Tiffany and Vinny we're going to get together and talk about how we can collaborate on this outreach to providers, because we feel like there's a place for that in terms of our communication strategies and some of the other work that this task force is doing. We also have some discussion about how it's becoming more apparent to us that there's this kind of chasm in knowledge between local health and healthcare, and so a lot of people feel like local public health kind of understands what's going on in the healthcare arena, and a lot of the folks really don't. And so in another life, I work with a collaborative that's comprised of local health departments, and this waiver and GBR and all these concepts are just really new to local public health. And so the waiver requires that groups start working together, but we recognize now that there needs to be an understanding on both sides. And so I had Rob Cohen from AHC to come and talk to that group a couple weeks ago. I think it was a couple weeks ago, and Steve came and spoke several months ago. But Rob had never been in a local health department, or he hadn't been in one in a while. So he came and he was like, wow, this is really great. He was health in Howard County. He was really impressed by the layout and the collaboration that was going on, and so he felt like it was really revealing and eye-opening for him. And when he was speaking, a lot of the locals were kind of, their eyes were glazing over because they didn't understand a lot of the terminology that was being used. And so Rob and I spoke, and we also talked on our subgroup meeting about ways that we can start to help the learning from both sides so that we could make
we can optimize this effort and make sure that people first are coming from a kind of a shared foundation of understanding of this whole problem and then trying to move forward. Or not a problem, but opportunity. So stay tuned for that. And I think that's it. We talked about, I just shared what has been going on in some of our subgroup work and the task force work. Did I leave out anything? Anybody on the group? Over here on the group? No?
You look like you have a question. Or is that just your cold? Okay. Okay. Okay, so turn myself off. So let's then turn to the work that the subgroup has been doing. And the last time we met, we had organized one subgroup, which was focused on charge 1 of the for the task force. And not much work had been done for charge 2, which was the one that was focused on the communications consumer pathways. So the way that it has evolved, assuming that everybody agrees to this, is that rather than having a subgroup for charge 1 and a subgroup for charge 2, we're just basically merging those two subgroups. So they've been meeting, I think, every other week to try to put some meat on the bones of what we've been doing. And I thought maybe I'd start with subgroup 2 if I could, which is the, and I think, did everybody get a copy of this, the charge 2, or did that only go out to the? Okay. So for charge 2, it may have only gone out to the subgroup people. For charge 2, Tiffany asked me to kind of break down a bit more what that charge 2 was all about. And so it's the ability of consumers to provide feedback in an easy, consumer-friendly way that can be used for a number of different purposes, including the identification of the elements of the new all-payer model or its application at individual care settings that could be modeled for other institutions or systems, identify issues or barriers or challenges at specific care settings or across the system, systemic ones, and look at systemic issues or potential, I said, flaws in the new all-payer model design that should be addressed in some way going forward. So to me, the most important part of it is that we sort of articulated, and the group this morning agreed to this, and I certainly hope that Steve doesn't say, what the hell do they think they're doing, but on 3 areas that we would provide feedback to the commissioners on, specifically on the consumer pathways. And one is how consumers are made aware of their rights at hospitals or in other related facilities that are a part of the new all-payer model, what processes are in place for consumer feedback in areas relevant to their own care or addressing the caregivers, and the opportunities for participation on advisory boards or related committees that they can then serve to increase opportunities for consumer feedback, but they can also be used to, if we can get that to Steve, can be used to inform policy changes going forward to address what might be working and what, to close that up, and what might not be working. So I know that, well, actually almost everybody that was approved of this earlier this morning is in the room, but are there any thoughts from others, or Steve, having now only seen it for the first time, whether he has any thoughts on whether we're on the right track?
It seems to me that, yeah, that we are on the right. You are on the right track here. You know, there are opportunities, and perhaps, and I didn't. There are plenty of opportunities in existing regulation for consumers to have say. So my point is, some of this is actually backed up by current existing regulation, and I'd be happy at some future meeting to go through some of, particularly relates to billing and credit collection and things like that, but there's some other provisions. So I think this supports some of the provisions of existing law without having looked at it in detail and thought about it, thought about it. But I would think that hospitals would be, many hospitals are probably trying to find ways to get to this, and now you have a resource. This committee can help them in that process.
Yeah, so just to build on that, because we had a meeting that started at 8 to discuss this, and Teresa has been doing a lot of work and analysis of what is in place at the hospital level on the areas of patient rights, the consumer feedback process, and whether they have an advisory council is actually what we're specifically looking at. So, and then we're also looking at what other agencies or institutions collect this kind of information, and how that would feed into the new all-payer model and what more work we need to do in those areas. So maybe, Teresa, if you want to sort of report out.
So there are a couple of things. They had a lot of discussion over 8 o'clock today.
Teresa, you want to use the
Oh, sorry. I think I was now.
So we focused on those 3 areas: patient rights, consumer feedback, and opportunities for participation in advisory boards. And we reviewed each of the hospital's websites to see if, in fact, those 3 areas had been addressed. So that review simply gives us more information on what's reflected in the hospital's website. It doesn't mean that the hospital is not addressing any of these areas. At this point, this is a first review of the hospital's website. So that review showed that about 39 of the 47 hospitals address patient rights in their website fairly clearly, and that there is a complaint process addressed, or at least the issue of consumer feedback is addressed in about 27 of those hospitals, but only 7 hospitals address patient or family advisory council. So there's definitely opportunity for facilitating additional hospital change or addition to their website, but in general to get the word out to encourage hospitals to get the word out and maybe participate in programs that are already available, i.e. the Maryland Hospital Association. I reached out to Nicole Stallings and had a great conversation with her. They've actually in the past year had programs to encourage hospitals to develop and implement patient and family advisory committees. So we had some discussion about perhaps talking with MHA to work together on a collaborative process, and perhaps adding a survey to gather more information. So that was discussed. And then we also reached out to the Office of Healthcare Quality to ask more about the complaint process. And there was a lot of information that was captured, and we went over that. And perhaps there'll be a presentation in another meeting from Renee Webster of OHCQ.
Just talking about the Patient Advisory Council, it struck me with Carol, they're not one of the ones with the Patient Advisory Council. So looking at what other alternate ways they provide for patient and consumer participation. So Gary had a great point about the survey question, to be sure that you open it up in such a way as to capture that information.
Right. And again, that's why I want to emphasize this is a review of the website. Because it's not on the website doesn't mean it's not in existence. So which is why we're just using this as an internal document at this point.
And, I mean, and to that point is that if it's not clear on the website to a trained eye how to find that stuff, then that's potentially one of the recommendations going forward. Does anybody want to add to that or have other ideas? Did I space out if you were talking about the Arundel Advisory Council, and that we might.
Right. Arundel is one of the hospitals I spoke with. There were a couple of hospitals that MHA recommended, Nicole Stallings recommended in terms of having really good programs and perhaps best practices. Arundel Medical Center was one, and I spoke to a representative from Arundel. They were very enthusiastic and went over, similar to what Carol is doing, a lot of the activities in terms of engaging patients and family members. They have over 90 patient advisors, and they're participating in over 50 committees, something like that. But they're also interested in presenting at a future meeting so they can share their experience, and then other hospitals can perhaps learn from what they're doing.
So those presentations we were going to do within the smaller subgroup rather than bringing it to the full task force. Any new thoughts from Carol or other things that should be considered as part of what this group is doing? Our immediate tasks are to continue to fill out the hospital one, although that's pretty complete, and then to look at the other pathways for communications, whether it's at the Office of Healthcare Quality or through the Medicaid program. So we prioritize some of those because it's so complex for consumers to know where to go to get what.
The other thing I didn't mention is the toolkit that's already available that AHRQ has created for hospitals who are interested in getting started and establishing these councils and how to engage patients. There's an application form, quite a bit of information in that toolkit.
Anything to add on that?
I don't mean to open a can of worms, but I know one of the things we've been struggling with, and I know we asked Carol this, is how to measure this patient engagement. And I thought that Carol did a good job of kind of just bringing it back to their, their hospital, their SHIP measures, that really maybe you can just measure it that way. I don't know, I'm not trying to bring this back there, but I know we've been struggling with that. I don't know if that's a charge of the group if we actually have to resolve that struggle. I think one of my, how are we bringing this all together questions.
Well, I think ultimately the Commission wants to measure performance and show evidence of effectiveness in all of the work that we're doing. So that would include engaging consumers. And I think that's a big philosophical or theoretical question, or both, around do you measure a process, how many people are you getting peer-to-peer intervention versus what's happening at the end of the day? Are you really seeing a reduction in ED visits? And we're sort of in the outcomes path at the moment, but not to say that we shouldn't measure a process, because as you're trying processes to see whether they're working, you have to know that you're delivering the process. So those seem to be good metrics for early operation or implementation. But really, what you want is for whatever you're doing to be causing the impact that you want, and which would suggest outcomes. And
Carol's a good example of figuring that out.
Right.
In a day that's hours.
So, well, if we're looking at the avenues for consumer feedback in order to inform policy, are the numbers of calls going up? I mean, if you're going to measure, oh, I know, you're shaking your head.
I think that's important, the numbers of calls, but that gets to Di's point about process, because really, if there are 50 now, what did we do with 49 of them? What outcome happened from them? And so that's the tricky part, measuring. I mean, sort of what I was trying to get at earlier, too, is how do we measure which of the interventions are the ones that got us to the outcomes also, which I think is something we've always been challenged around. Well, was it our coordination, care coordination intervention? What is the piece that's doing it?
So, I mean, I think that's an important question to keep on the table, right? But
there's also a measure, I was just reading in this, there's an article that gets us in Basecamp now that talks about individual and family engagement in the Medicaid program, and they make reference to patient activation measures that NQF is working on. So there's something else that, there's some more information that we can look into to see if, in fact, there are measures that would help us demonstrate that these are effective interventions, or which ones are effective.
And if I could just add to that, if you look at the National Quality Forum, there's also some new metrics that are being recommended in terms of care coordination, patient activation, all those kinds of things, and maybe that would be a resource to look at too.
so maybe we should pull those together. I think there were some also in that paper from Australia that looked at the national health system, the U.S. health system, and that, in fact, I believe is where Kaiser's program was highlighted. So we're going to be talking to Shannon Hines, who's on this group, but is not in the room.
Will you please email me some reports?
Is everybody using Basecamp, or does that stuff need to go out on a regular email? Everybody's smiling. Okay. Well, you left a message on it. That's more than some people have done. So.
It was interesting, though, Sharon. I really appreciate it.
Okay, so if anybody has thoughts in the middle of the night about consumer pathways on this consumer feedback, you know where to find us. So let's move on to charge 1, if we might, and look at. I think you've all got the communication strategy chart, and the top piece of that is the prime stakeholder piece of it, the high utilizers, the dual eligibles, and the Medicare beneficiaries. And two things. Hillary had done some work looking at how to break this down geographically and whether that was a useful process. And then, so maybe, would you like to talk about that a little bit first?
Sure. I can talk about the geographic targeting, and there is actually a handout in the packet that looks like this. So in one of our Charge 1 subgroups discussions, we talked about the potential for trying to look at geographic areas so that we can focus efforts a little bit in the places where we're most likely to have quicker impact and begin to move the needle. And so I looked at 2 data sets that HSCRC already has available, and it's important to note that these data sets were pulled for different reasons. They weren't specifically created for this purpose. They were just existing data that we could look at to think about geographic targeting. And so I'll go a little bit into what I found from that, but before I do, I want to mention that it's very important to keep in mind that although there are suggestions in this around geographic targeting, that is by no means to suggest that areas that aren't sort of highlighted here should not have efforts. You know, this is a statewide thing, and we need to look at all regions, including those who may not have as high numbers of high-utilizing patients, but that we can begin to move the needle by looking at the places where the numbers and the costs are great. So, so the 2 sets of data that I looked at, one looked at high utilizers as defined as people with 25 or more encounters in a year, and another looked at people with 3 or more encounters in a year. So there's quite a variation in that, but interestingly, the results were pretty much the same as far as geography. So one of the first recommendations, as I said, would be to phase consumer engagement efforts throughout the state by starting in the areas with the greatest numbers of both high utilizers and high costs. And if we initially target the areas that have both of those, we'd be looking at an Arundel, Baltimore City, and Baltimore County. In a second phase, we could target regions with either high numbers of patients with 3 or more encounters or high costs. And that's a slightly different mix. So there we would be looking at Hartford, Howard, Montgomery, Prince George's, Queen Anne's, and Worcester. And then in the next phase of communications, looking at the rest of the state that hasn't been covered in those two. The other important thing would be to leverage the communications channels of distribution networks that are already established in those areas by organizations that are addressing the chronic conditions that lead to high hospital use. So not reinventing the wheel, trying to find new ways of getting to people, but providing information that enhances the existing communications pathways. And then finally, just to reiterate that this is not to suggest that we don't pay attention to the whole state, because I know that had been a concern when we first started discussing this. It's just to say, begin where we can have greatest impact early. And then the rest of the 2 pages is just a summary of how I came to those recommendations. I won't go into that.
So are there responses, thoughts to that concept? Yes.
Can I make a comment? Thank you. This is really good work and starts to help focus. One of the things that I was thinking about is, and unfortunately our Tableau data is county oriented, but it seems to me that particularly in many jurisdictions that the effort, the high utilizers, and the focus should be on more surgical, to use the term, in communities. There are certain communities, for example, Baltimore County, very large county. I'm sure there are areas of the state where, or the county that don't have a propensity for high utilizers, and then there are areas that do. So you're working with the data that you have, and appreciate that. But I think the next phase might be to take it down to more zip code level and to target those areas.
Yeah, I would absolutely agree with that. And I'm not sure. I'm sure that there is data like that out there. We've just got to find it and pull it in. But I absolutely agree with that.
There is, and I would argue the zip is too broad. There are blocks, neighborhood census blocks, that are more prone to, certainly there's demonstration that there are higher mortality rates in these very small geographic groups. And we are working on something called the Area Deprivation Index. It's right now synced up with the 2000 census data, and it looks at probably 17 different characteristics of an individual that we could collect in our administrative data, and then we could, a Dr. Singh from HRSA developed this in the public domain. There's work currently being done to, it has to be linked to what the current census is in a particular region, so that you can line up the index with what the current population is and their characteristics. So when that 2010 sync up is done, then we're going to take that programming and try to see how it impacts things like readmission and mortality. And we could use it for any number of things, including consumer engagement, in my view. But that won't be ready until toward the end of the year. So just so you know, this group's recommendation could be to use whatever available analytic power that we have at the time to really look at discrete geographic areas at risk and for targeting of these consumer engagement efforts.
One of the things that comes to mind is what we heard from folks from Carroll County talking about, you take the information to where the people are, which I think is spot on, but I think that we also mustn't lose sight of the fact that people move. So we can think about people where they live, but we also have to reach them where they work and play and worship and so on. And so while I think that there is value in looking at those specific zip codes of residence, we do have to have wider efforts because people are there for 12 hours of their day and 8 of them they're sleeping. Making a generalization, but so that we've got to reach people throughout the community.
Yeah, so I mean, Howard County has done hotspotting, and they've got the apartment buildings where the seniors live, right? Same as in New Jersey. So, I mean, I think our task is not to identify down to the building level, but to create that construct that includes the geographic and more geographic breakdown. But I mean, I completely agree that we've got to have the big state picture, right, messaging. And then in phase 1, hone in on some of those target areas that are high volume. Yes, Kim.
I just wanted to say I like the
picture.
Oh, thanks. Yeah. I like this piece about leveraging communications channels and distribution networks already established by organizations. Made me think that we could really leverage the community health workers that are affiliated with those organizations as they're the trusted deliverer of messages to those communities.
Hillary, I know.
Yeah, go.
I know I was the one that was kind of critical from a rural lens, and I commend you for doing this because digging into data is not my skill set, and you went and did it, which is great. And I mentioned this, I think, to kind of piggyback off what Steve says and using St. Mary's as a county, I would just advocate from a rural lens that we empower more of that local messaging. Because, you can, St. Mary's has as an example of that, where they identified Lexington Park and are, showing some outcomes and engaging consumers in that area. You just, from a rural perspective, we just have to be very careful at looking at raw numbers of high utilizers, because we know our most chronic, or a percentage of population, we have more chronic disease in our rural areas. So I don't know what the measures are to use for that, whether it's just plain admissions and I'd be curious with this new data set what, the hot spotting, what the measures they're using are, because that's not my comfort zone. But I would, I just think we want to spend more time on empowering the local engagement and the local perspective. But I do see the value in the statewide targeting. And I think what you laid out really makes sense from that statewide lens. I just think it's this data issue, like having that best data to kind of know where you need to engage. It's so important. But it sounds like we're getting there.
So maybe I wonder. Maybe thinking about defining the target population, so some of those target populations were defined by the care coordination work group. So do you want to talk about that work group and how they felt consumer or patient engagement should happen, and then we can kind of throw that open for discussion as part of this?
Yeah, so as you know, the Care Coordination Work Group started months ago. They had 6 meetings. I think Susan was at all of them probably from in this room. Not a member, but nonetheless, I think.
Engaged.
Engaged, yes. And Lenny was at many of them as well. They've come to a point now where they've had their final meeting. They're in the process of review of their final report. And they brought people together around the state who are involved with care coordination. It's a multi-stakeholder group. And they've also brought in people to speak from outside, from San Diego and some other places that have some innovative strategies that are in place that are being successful in some places in Maryland too. And brought in Kaiser from their perspective, who has both, from the payer and the provider side. And I think there was a lot of really good information. And this is, I think, right now kind of the next stepping off point for improving care and transitions of care. So the group was focused on several, and you have in your packet there the draft recommendations. It doesn't include the most recent draft, which is still in the process. And kind of the focus, well, the very general focus is on, one, accessing data so that we can identify and do stratify patients by high needs in however you would determine to define that. Secondly, to be able to have a system in place, infrastructure in place, where we can share those data between and among not only hospitals, which right now the HSCRC is really good at providing readmissions and stuff like that for hospitals, but across all the community providers. Physicians, some physicians are attached to CRISP, few, not all. Other behavioral health, other community providers, post-acute, et cetera, long-term care, so that they can share information, be able to know where patients are in their process. The other thing is trying to provide some elements of some common information that should be shared as part of this process. Like we've talked a lot about care plans or care profiles, as some people may call them. So as when the physician decides, all right, this is the care plan for this patient. They have these chronic illnesses. This is the direction for this patient. To be able to share that among not only just the healthcare providers to the extent that HIPAA would allow, and that the consent is provided by the patient, and it doesn't violate any privacy, but that it could be not only shared with healthcare providers that are putting hands on that patient, but also to help with the social services that the patient may need to be able to share that information. So some of the challenges there are consent and privacy. We recognize that, and that's going to be a priority in these recommendations. So having said that from a very broad base, in your packet, this appendix here is really kind of some categories of recommendations. It's Appendix A. It's toward the end of it's at the very end of the report there. While Kim's looking for that. Or no, actually, I have the full report. You just have the slides, right? You have the slides on your desk. Yeah, you have the slides on your desk there. So the first thing, as I mentioned, is to build infrastructure to facilitate identification of individuals who benefit from care coordination. They are those high needs patients, particularly focused on Medicare and Medicaid dual eligibles, and also behavioral health, which, as we talked about earlier, is a really difficult population to deal with. So the initial focus, I think, right now is getting the Medicare data to be able to share those information. And so the high-level goal here is to secure, organize, synthesize, and share data that will support care coordination, enable more robust care management and monitoring across the continuum of care. The second category of recommendations is to encourage and support patient-centered care. The goal is to identify standard elements of care profiles that can be shared, propose future standards for creation of individualized care profiles. So as I mentioned earlier, the challenge is we talked about creating a standard care plan, but as trying to create anything across hospitals who have differing systems is always a challenge, but at least we could put elements, common elements that need to be in all those, so when a physician in the community can understand what this means and what the priorities are, what this group believes are the things that people absolutely need to know. And of course, the hospital itself and their EMR is going to have a whole bunch more information. We don't want everybody to have everything, not that even would be permitted under HIPAA, but it would be actually counterproductive for the physicians in the community, because many of them will just say, TMI, thank you very much, but I'm going to work with the patient with what I have.
Can I just, I'm sorry, just check out it. So it says, talking about the care profiles, create health risk assessments and care profiles that should be readily understandable to the patient. So it's securing a contractor to convene providers and create these, right? So I would just say that as a point of consumer engagement, if they're to be readable by patients, those should be part of the conversation.
Okay.
Which we'll come back to that, Steve, I think, when we get to
the next one.
But I'm sorry, it's just,
yeah.
Page 3, the top of page 3 on the right.
I'm sorry.
Implementation strategy.
And which on which one is that in? Is it?
Well, I was looking at
B1?
B3 actually.
B3.
I'm sorry, the top of page 3. I knew where I was.
Oh,
Yeah. So B3.
Yeah.
Ensure protocols are ready for understanding by the patient, right? Okay.
Yeah.
Okay.
For a second, maybe it's inherently understood, but it's kind of it's not showing up in the language, nor did it for the Carroll County folks that were here. For a lot of individuals, it's their care partners or their caregivers, their spouses, their parents, their children, because the individual may not be able to fully participate. So I just want that to always be in the scope of things that we're talking about.
That's good.
Yeah, and so I haven't looked at the old version, so I have to see how it's been changed since it's 3. Yeah, so there's been actually something added since then that addresses, I think, maybe potentially both of these issues. It now says to use BRFA funds to secure contractor to convene providers, and perhaps we should add and patients, and create health risk assessments and care profile elements. Patient representatives will be engaged in the process to ensure that these profiles are readily understandable to the patient.
So you might add health literacy. I would like to see health literacy experts put in at every, my best example is an MIA form for HIPAA compliance, and Brenda Wilson said that after the consumer advocates got engaged in revising the form, and specifically Linda Alduri, who's actually on this committee, that they went from a 90th grade level to a 9th grade level. So
Can you hear me?
is that Linda?
Yeah, I've been on the call the whole time. I just have been listening and writing notes.
So I don't think you were at that hearing in Annapolis, Linda, but that was impressive. And I know that you or others had worked with the MIA on that bulletin.
Right. We sent representatives, but no, I wasn't there myself.
Yeah.
And perhaps we should say understandable to the patient and caregivers or something like that in there to address that concern. And I should say, by the way, and we'll get to this on the next one, Lenny did provide an email with some changes, and those changes have been considered. I actually made sure that at the last meeting that those were, one, heard by all the whole group and not just by staff and Jack Meyer. And so they did hear that, and they did make some changes related to
And I know, Kim's at Mental Health Association, Adrian Ellis is on
right.
that committee, and I know she waits.
Yeah. So the next one, the next category is which is something you're very interested in, is encourage and support patient engagement, decision-making, and self-care. And this would recommends leading a statewide campaign to encourage individuals to participate in care plans and complete and share medical orders for life-sustaining treatment, most. And so it would have a state and county campaign and engaging patients and families in care planning and consents together with consumer groups. We added in there, including HSCRC Consumer Engagement Task Force and also both task forces, also the Outreach and Education Task Force, to include them in the process. And we acknowledge that right now, it's difficult to find resources for this purpose. And so we added in here, adequate funding for these entities is required for success, which is something else that you all brought up. Clear and consistent messaging should be developed and used across the state. And then the second item is educate patients about care coordination resources and opportunities and mobilize self-care. Giving patients appropriate and timely information is the key to the patient activation. We also, as part of this process, included the two work groups, the consumer work groups, in here as somebody who should be included in that process. D, which is the second to last item, is, of course, encourage collaboration. I don't know that we need to talk about, we've talked enough about the importance of collaboration. And then finally, we also talked about E, which is connecting the providers into the HIE or whatever mechanism is in place to share that information. This is going to be, I think the recommendations of this task force are really going to have a major impact on healthcare delivery. Many hospitals, it's like anything else. Some hospitals have already gone down this path. But the problem is we need to go down this path together, because otherwise hospitals can get down the road and they can't turn back in a patient-centered, to make sure that we do it in a patient-centered way.
Did the group talk about e-health or patient health records, not just connecting the providers, but so that patients can be connected if they want to be? Yeah, portal. Did they talk about that at all?
We didn't really talk much.
I don't remember that there was talk about that, but it is to allow some kind of mechanism for patients and community members who care for patients to have the ability to influence or have a voice in the process. So I think that there's a lot of energy around coordinating care, a lot of different models and things that everybody's advocating for, and I think that people want to participate, but there's not a mechanism.
Right, and I should say that this task of connecting all providers is a huge task. It's going to take some time. We're going to have the HIE policy board, which includes a lot of consumers and other folks in the community, are going to need to address many issues relating to consent and privacy of information. This is so just what we have here. The portal seems to me, once we accomplish these huge tasks, that the portal would be something that would be important, but kind of easier once you get to that stage. But
well, we know that this is something we're building for the future, and as I said earlier in the meeting at 8, was that, people in this room, there are some people in this room that are so used to technology. Our elders are not necessarily, but coming up in the ranks, and as they age, they're going to want that for the consumer to, be able to influence the process. If any of you have read the Washington Post every day, there are articles, and you look at the comments, and there's already been 2,000 comments. People want to participate in the process.
And in fact, I think, again, maybe it was in the Australia paper, but one of the targets for patient activation was providing access to their EHR. So we'll put it, as Diane says, it's in the parking lot. Mm-hmm. But yeah, that was a great point. Yep.
I also think that one of the things we don't want to miss is people. This is very provider and hospital and professional driven, and that what we have found in all of our work on the ground is that people's own identification of their goals and so that motivational interviewing and the piece that's involving the consumers themselves and what are their goals, because they don't care about their lab results necessarily if they really need to get to their methadone or they really want to see their grandchild. And so if we don't have that as part of the model and the design from the get-go, I think we'll all be sharing information with each other, and we won't be touching the engagement, real engagement.
because of the behavioral health issues, I just wanted to make mention of the Mental Health Advanced Directive. So on the encourage patient engagement piece on page 3, letter C, you make mention of most, and I just wanted to say that there are probably lots of places that we could tie in the behavioral health comparable, and so the Mental Health Advanced Directive might be an important thing.
Kim, can you talk just about 30 seconds a little bit more about that, like how long it's been around? I don't know about it. That's why
it has been around for a long time. I think it was in the 70s or the 80s. But Maryland, a bunch of stakeholder organizations got together with the Mental Health Association, I think it was 2006 or 2007, to try and make a consumer-friendly Mental Health Advanced Directive. Because what often happens is when people get sick and go to the hospital, they refuse treatment, they dispute, so there's a lot of conflict. So the goal is mostly as a consumer empowerment tool to have the person, when they're well, make decisions about the care that they would get when they are deemed to be incompetent. So it only kicks in when 2 doctors say that they're not able to make decisions. And the Mental Health Advanced Directive can spell out anything, but it's super important for people to be able to say, I've had this medicine before and it makes me throw up, or, I don't want this kind of treatment, or don't touch me. So they can really specify those things that are better for them in terms of recovery. There was a bill in this General Assembly, and the outcome of it, I don't know that it's going to be legally enforceable, because the law says that anybody at any time can revoke their Mental Health Advanced Directive. So what happens if I'm sick, Susan's my doctor, I have my Mental Health Advanced Directive, but I'm sick, and I say I don't want that, cancel that, rip it up. Well, she, as the doctor, knows that she has to honor that. But there's this place on our Mental Health Advanced Directive that says, if I say that when I'm sick, ignore me. Because a lot of people will say that when they're sick. So that hopefully the providers will say, we're going to follow your Mental Health Advanced Directive until you're a little bit better, but we're going to stick with this. So that's kind of where we are with things.
So I think, I can mention this to Jack in this review process. I think it's something that the committee didn't discuss. We did discuss most a little bit, but they didn't discuss this. It might be difficult without another committee meeting, to add that in there at this stage. But I think it's something that going forward we should, keep in mind and learn. And I would like to learn a little bit more about it.
From the consumer engagement perspective, we want people with serious mental illnesses to trust that they're going to get the care that they don't see as harmful. A lot of folks have felt harmed by care that they've gotten in psychiatric hospitalizations. So even if it's not written in here, I think it should be a tool that we're all aware of so that we can encourage people to be engaged. But, obviously, if their Mental Health Advanced Directive is not honored, it's not that it's doing much for a trusting relationship.
I do believe there was discussion around end of life and health and advanced directives in that regard, and I don't know why this couldn't be something that was kind of.
This is not really end of life.
No, but
it is an advanced directive.
It's an advanced directive in another way, in terms of, when somebody goes into a psychotic break. In some respects, it can be the end of a period of life, if you will, especially if they're going to end up in a state facility for, several years. So I just think it kind of goes hand in hand. I don't know that it can be incorporated, but
I will suggest to Jack what you all are suggesting here. It may be too substantive for him to add into the report without going, talking to the committee about it. I just don't know enough about. There may be other issues that I'm not aware of, or we need to hear from the various stakeholders on it.
One of the things that occurs to me is we've talked about CRISP as a way to share information amongst providers. If we had CRISP or a section of CRISP that was eligible for the patient to share their own information under a heading like, how do I want to be treated when I go to a healthcare facility, and then provide resources, standard resources that they could use for an advanced directive for end of life, an advanced directive for mental health care, et cetera. It would be in a place where institutions and their primary care docs could access it if it were needed. I know I would find that to be useful myself, because while I've given a copy to my primary care doc and I have a copy at the hospital, if I crash my car on the shore, do I think that that's going to get there in time to let people make appropriate decisions? I'm not sure it will. If we have a state resource that could provide me with the opportunity to put that in there, I'd sure rather have that in there than a lot of other things that probably will wind up there.
Yeah, sure. So the next stage of the process is actually the committee is asking CRISP to come up with a timeline and a plan to meet a lot of these requirements, and a lot of details, of which the devil are going to be in the details. So it doesn't preclude any of these things during that policy process that they're going to be making to include most or the mental health advance directives or anything like that, if they see, one, that it's doable, and two, if they find value in it. Because if there's value in it, folks are going to pay for it, pay for the cost of doing it. So just because, even if it doesn't get in this report, as you said, we've got this forum and there are other forums down the line that CRISP is going to, their HIE policy board would be one of the places where they would consider something like this.
Yeah, I think we appreciate the fact that the report is far along, and adding something, we don't want to complicate the process, or we want to roll it up.
But this is an issue, I think, at the right point should be, if they're talking about most, then this should be something that should be discussed among stakeholders to ensure that it's doable and appropriate.
Yeah. Do you have a comment, Hillary?
So this is moving away a little bit from the CRISP thing, but just something to keep in mind in terms of the consumer engagement side of this. A lot of the way this coordination piece is presented assumes that the patient is necessarily connected to their primary care provider, and while there might be someone assigned or their insurance company thinks they're connected and it might all work out in the paperwork, that individual may not know or may not go. So one piece of the consumer engagement part of it is making sure that everybody understands the pathways that happen in the hospital and in the community. And so we need to keep that very much in mind as we're talking about these things.
Which goes back to health literacy and ensuring that people actually understand what their primary care provider is.
And on the reverse side of this is there's also a concern that patients could be confused by care, multiple care coordinators involved in their process. They could be with Care First, PCMH or something. They've got a care coordinator there. Then the hospital says, "All right, we got chronic illnesses. We need to deal with you." And they're going to say, "Well, just somebody at Care First told me I need to do this." And then you have somebody else's care coordinator coming in and providing. So there could be some some confusion there. So it can go both ways. And obviously, care coordination is not going to be for everybody. It's going to be targeted because it's very expensive. And so you need to target the top 5% or something like that. Otherwise, it's just unsustainable. There's no way you can, so not everybody is going to get this level of care coordination and help with navigating through the system. It's just these high utilizers that we've been talking about in the short term.
So, go ahead, Karen, and then
So I just want to tie into Hillary's comment in terms of the evidence-based care coordination practices. that, like CTI, that have a connection with the primary care out the door, which is making sure appointment is scheduled and connected to that person out the door, and that would get at that for those high utilizers.
So, so the next big task, as we've done a better, moving towards breaking down the high priorities down into higher priorities, if I can put it that way, is that we'll next then be looking, it seems to me, at within that construct, who are those primary messengers as we move towards figuring out what those messages are. Does that make sense, everybody? For our little chart. So having identified the 3 primary groups and begun to identify with the geography and the discussion today how perhaps to break those down even further, we can then start to look at more concretely the messenger groups, which is basically the rest of the chart, right? And how are they going to intersect, who are going to be the high priority. Does that make sense? As we eventually move towards getting what those messages are. So the information from the forums should help to feed all of that as well as far as the message is concerned. Okay, so if nothing else on that, the timeline got updated, the operational plan. Do you want to talk about that? I think the main thing was the reporting.
Right. So there aren't any significant changes. We have, I don't know,
Sure. So I presented to the commissioners a month ago, and said that the time frame we were looking for reporting out was a preliminary report in July, because we won't have all the data yet from the forums. And then we would do a final report in September that would create the communication sort of strategic plan approach, and not necessarily hand them the communications plan, because there's not time or resources to fill that out. So that's our current time frame, is working within that first crunch of July, beginning of July. Their commission meeting is, I think, the 9th.
Whatever the second Wednesday of
July. Yeah. So it's, you know, and it's early in the month, if I can put it that way. So and then we've got vacations and so forth. So trying to get as much in at the beginning of July, but knowing that we won't have the full report out from the forum, so from the consumer perspective on the ground.
So there aren't any major changes to this. There are a couple of additions, and also relaxed the timeline a little bit because we were working with that June deadline, and now we've been granted an extension. So the 2 additions that actually, there's just one major addition, which is the last one, and it's just talking about the changing of the timeline to submit our reports. And so we'll present a preliminary report in July, and then the final report in September, after the Consumer Outreach Task Force has had an opportunity to complete the majority of their forum and report back. And then also, they're planning to have their report due a little before that, and so we'll also be able to have some learnings from their deliverables.
But I think that we felt that by the time we were into mid-June, having done a lot of those, we would have real trends in the consumer feedback, so we could do something constructive and not have to wait for the final report from the forum, because those would really push us back. Mm-hmm. You're looking at me questioning, but that would, yeah? No? Okay. So does that make sense to everybody? Okay. So agenda-wise, I just lost that piece of paper. Okay. So we have no public, so we don't need public comment.
Public's here.
The public's here. The public's sitting around the table.
That's right.
That's right. Oh, Nicole, are you on? Are you still on the phone? or other non-group members? Okay. Okay. Well, those on the phone, feel free to speak up. So I had put together, and I guess that went out, a very long list of proposed scheduled meetings in order to get this work done. For the full task force, and Tiffany and I will work on finalizing those dates between us and then get those out to the group, to the subgroup in particular, and make sure that they work for them. For the full task force, our next meeting then is Friday, May 29th, and we had discussed before having some folks who are working on the ground do presentations, and specifically we talked about Primary Care Coalition, talking about its Health Partners program, and then Karen Ann in the Coordinating Center, and Susan with Healthcare Access, and then Michelle had recommended Deb Geller, who's the health officer down in Worcester County, to present. And we had another idea thrown at us this morning, and as Tiffany said, 5 presentations, 2.5 hours, and a lot of work to do when we're kind of pressing up against the deadline may be a bit challenging. So I think we should go back and rethink that. And I think what would be really helpful is if Karen Ann, since you're still sitting in the room, and we'll ask Susan as well.
Last woman standing?
Yeah, last woman standing, yeah. No, I think that's me, honey, but could you do a brief, Hillary sent me like a, a brief description of the program. If we could get those from the folks that we were talking to, I think it might help us to decide
What you want to have. Sure.
which ones we should really have come to the table. Does that make sense to you, Tiffany?
Sure.
Okay.
Happy to do that.
Okay. And so we'll ask Susan to do that as well. Okay. Anything else on anybody's mind that has not been covered at this point?
I just would like to thank the group for doing a lot of work in a short period of time and your input, particularly on the care coordination and other things with the commission. Lenny was at almost all and spoke at several of the care coordination work groups. So I just want to know your presence is deemed important in those groups, and it's been heard. And we look forward to continuing, the process both with the commission and other activities of the commission. So
thank you. I mean, I think we're all, as consumer advocates, incredibly appreciative of the HSCRC's commitment to it, and to Diane's time, and to having Tiffany on board, and Teresa just did just an amazing job on pulling all that hospital data together. So I was thinking this morning, there is something about being in the same room or the same building with different folks, right? There's an energy there. So thank you. So we'll be in touch. We'll follow up on the steps from the work group this morning, the small group, and then follow up with some proposed dates shortly. And in particular, too, about getting the speakers that Teresa had recommended for the other subgroup. Great. Same time, 9:30 to noon on the Friday the 29th.
And is that the date for the presentation if you want, should you determine the presentation?
That is correct.
Okay, so it will be someone other than me who makes the presentation, because I won't be here. But.
Okay. Well, we'll just have to take second best. What can I say? Okay, I think we are officially adjourned.